Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a great honor for me to introduce Charles Fanlow. He is the implant planner and works up surgical cases for the NSequence lab in Reno, Nevada. Charles, thanks for being with me today.
Thank you so much. I appreciate it, Doctor.
You are the implant planner and work up case flow right now for the NSequence lab. Why don't you tell people who NSequence lab is just a little bit?
So, NSequence is not only a traditional dental lab where we do crowns, bridges, full upper dentures, that sort of thing, but we also have our surgical guides and our patented NSequence guided prosthetics, where we do, the all-on-X, as some call it all-on-4, all-on-5, what have you, guided procedure that not only guides your implant position, but also guides your abutment position for your multi-unit abutments, as well as how the long-term provisional bridge is delivered as well. So we basically take all the heavy lifting out of what would be a traditional conversion of an all-on-X. We do all, we cut the cylinders down to follow the lingual side of the bridge. We do all that stuff. So what you guys can do is go in there, be as efficient and productive as possible at time of surgery, as well as, single tooth implant cases where we do, immediate provisionalization, those sort of things.
Great. So if I'm looking to place one tooth to replace them all, you guys could have different services to facilitate that. Is that correct?
Correct. And we have an outstanding team of engineers. And so if you think you have something new that you want to try out, we've got one of the finest teams in the dental world that is able to troubleshoot, figure out, and, get you something new, perhaps, of, helping you out in your dental implant practice.
Now, you guys work with most of the major implant companies. If I came to you and said, hey, I want to do a case with, Nobel or Straumann or Implant Direct or, Astra, you guys could work with most of the major ones?
Exactly. I would usually say like the top 10, and then, a bunch of the other ones. Everyone from, like you said, Nobel, Straumann, BioHorizons, 3i, Zimmer, Neodent, MIS, Implant Direct, Hyosyn, all those.
Okay, great. So let's break it down into two categories. You've got maybe one or two teeth, and you've got a whole arch. So when it comes to single tooth replacement, what are some things like if I want to do guided surgery? Most of your clients, dentists, maybe send in you upper and lower models, a bite registration, maybe a Facebook transfer, copy of the DICOM for the scan, and kind of is that where the case starts?
Correct. So if you're doing just a one tooth implant, say we're doing nothing in the aesthetic zone. So let's say from, 5 back and 12 back. We would need our online RX, which is filled out at nsequence.com. It gives us all the information we're going to need for the case, everything from name, patient age, doctor, where we're shipping it, those sort of things. And then we would, of course, need a CBCT scan of the patient. We prefer to have the full arch just because that'll allow us to wax up a tooth within the arch and the models, make sure everything is aligned perfectly, because what we're going for is precision. So we'd like a full arch, and then the models, of course, bite registration. We want the bite registration as well in the scan, okay? Just so that it kind of helps us align everything, and it's just another piece of information that adds to our accuracy. So if you're for a one-tooth case, you will upload your scan. As soon as you're done with your RX, that will prompt you to upload your files. If you do STLs or intraoral scans, 3Shape or iTero, those sort of things, you can upload those as well with your scan. But otherwise, just email them to us, as well as the bite, because we like to have all the information with us. If you use VPS, which we prefer for your impressions, don't worry about pouring them up. Like I said, we're a traditional lab too, so you can just take the impressions and send them off to us. We'll pull them up here for you, and that's no extra cost. And then once we get all that information in for a one tooth guide, we get all of our team gets all the data together, all lined up, and then we have our admins give you a call and set up a virtual consultation. You'll go on and you'll view one of our technicians, because there's 4 of us. You'll view our patented software, the Maven Pro, and we'll sit down with you and we'll say, okay, how does this look, doctor? Where do you like the placement of the implants? Where do you want to move it? Is the apex in the right position? All these things, we make sure everything is dialed in before we even fabricate anything. Once that is complete, you give us the okay. It's usually around 3 business days, and you have your one-tooth surgical guide in-house with surgical reports that show you the drill sequence you're going to need to use, as well as the Maven report, which shows us relative bone densities, cross sections of the implant placement, implant sizes, all the information you're going to need to successfully complete your case.
Excellent. Now, with the bite registration, do you guys like that to be like a blue moose material?
That's kind of the generic name we use, blue moose, because it is a company. But for the most part, if it's a radio-opaque bite material, we're good with it. It doesn't necessarily have to be the Blue Moose company. I know Futar does well.
But you guys would like a radio opaque bite registration material and have that in the scan. So the patient's in MIP, maximum intercuspation, in the scan while that's being done.
Correct.
Okay, because a lot of things I've heard in the past say, separate the teeth a little bit in the scan so you can separate the arches. You prefer the bite down.
You'd be surprised at how much you can see. Sure. With that bite registration in place. It's pretty neat. Yeah, even with the teeth together, you're able to differentiate. And as well as, too, we have those models that we can also bring into the scan digitally to help us out with that as well. Okay, great. So that sounds pretty straightforward. I don't think there's many people that have any confusion with that. Now, when I prompted your company, when I said, I'm just a new client, I want to look into things, they sent me a kind of an intro packet, and it had 7 or 8 PDF forms that talked about all the workflows and what data to get, what information. It had a bunch of pictures. I mean, it really kind of dummy-proofed things so that I could hand the sheet to one of my assistants. I could check over it so that at each appointment I knew what I was supposed to do, what I was supposed to get, cases of what you guys want to send both ways. So I think those are really helpful. Let's talk about some of those a moment. Let's go into maybe the fully guided. Now, you guys, we can do fully guided a couple different ways. You guys can just provide the guide, or you guys can provide the guide and the full arch temporary prosthesis to walk through. So let's talk about that. What are you guys calling that process? The NSequence guided prosthetic delivery? Just what you called it right there. Okay. The NSequence guided prosthetics. Okay, so let's talk about that, because I think that's where you guys are really special and kind of groundbreaking. I know some big people out there are kind of lecturing on that process. I know Mike Picos has partnered with you and is kind of lecturing on this. So let's start with that and kind of talk with people a little bit about that process. Let's go through 2 scenarios. Maybe let's cover someone who's got terminally dentition that is going to be removed at the day of surgery, implants placed and temporized, and or maybe someone who's not in terminal dentition, who have already lost their teeth. Maybe they're just in regular dentures, because those are 2 kind of different scenarios. They both might be able to be immediately temporized, but maybe what the information you're getting beforehand or the surgeries are different. Maybe the types of surgical guides are different. Maybe one's tissue borne and one's bone borne. But let's kind of walk through both of those scenarios. Sure. So with the NSequence guided prosthetic, where you have someone who's terminally dentate, we got to get all those teeth out of there. So we talked about the initial records, of a 1, 2, 3 guide, as we call it. A couple, 1 implant. There's one other thing that we're going to need with the NSequence guided prosthetics, and that's the photo series as well. What the photo series is, and we have it on our website, so you can actually print it out. It comes in the new doctor packet, like you said, so you can see what photos we're looking for, because we don't have the opportunity to have the patient in the lab with us. So we need those photos in order to make sure that, that the bite in the scan matches the bite with, the photos, which matches the bite on the models, because, when someone's terminally dentate, they could have a different bite at different, times, depending if they're in pain or if the teeth are mobile. So we want as much information as possible, because we want that prosthetic bridge to go in there beautifully, midline, patient likes the shape of the teeth, all that. So the more information, the better. So and correct me if I'm wrong here. Is that the Coyce photo setup? Is that what I read? It is. Okay. It's similar to that, if not it. But also too, we're in the process of eliminating some of those, just because we don't necessarily need them in extrusion. You know what I mean? We can decipher that on articulators and models. The starting position is really what's important. And seeing the lingual side of the arch or how it lines up with the face, those major ones, but the extrusion ones, not necessarily. With the NSequence guided prosthetic, we need what's called the Fantastic 5, is what we call it. That's our online RX, like we discussed, the Blue Moose bite in the patient's CBCT scan. Now, with the CBCT scan for a full arch, we want, if your scanner can, we want 13 centimeters of view. So basically from the tip of the chin right at where the orbital sockets are, okay? We want all that because we want to see how everything comes together, including the condyles. We want to see that, okay? Because, sometimes, centric relation and centric occlusion can be different. So we just want to make sure, that we have all of our ducks in a row so that we don't mess up this patient's bite. So the scan, at least, at 13 centimeters if you can. Of course, if you can't do that much, get us the full arch that you're looking for and a little bit of the opposing. So we at least can align the models. Then we'll need, of course, the bite sent into us. We'll need the models again, and then our photo series. Those 5 things: the RX, the bite, the scan with the bite, the models, the photos. Those are the 5 things we need to go to that.
And that's all basically the records appointment. And we're doing our preparation, getting everything ready, sending it all to you. You guys are going to gather that, and then we're going to go right back to a virtual consultation. Is that right?
Correct. And what we'd like a lot of our new doctors to do, and actually all of our new doctors, is before you send that patient home at the initial records, call us before you send them home. Let's have a look-see together as a team and make sure that you're getting us what we're needing. You know what I mean? We can't expect you to give us exactly what we want without telling you. You know what I mean? So for that first, 2 patients that you have doing this, give us a call. Have our team look at the records real quick. We'll say, this is a little off, or this should be better, before you send your patient home so you don't have to do another appointment. Then once you get into the flow of using us, you don't have to call us anymore, and you get those records the way we need them the first time, every time. So it's just about the initial starting of the communication, because we're not just lab and practice. We want to be part of your team as well, so that if the communication is great, the patient's just going to benefit greatly on that. It's
going to make everything better. I mean, you've got to have good records. And,
oh, yeah.
I think not every dentist can, appreciates the miracles that labs do with the kind of the junk that sit in. But, you've got to have good input to get good output. So that's good that you guys are available to kind of quality check, even if the doctor's not going to look everything over too much, the assistants sometimes are just take an impression and run out the door. It's good that all eyes are looking at that. So we get all the information. You guys say it's okay. We get it to you. You get it all. You start to compile it and kind of walk me through that. I mean, what are you guys starting to do on your end of it?
So we check out the scan. We get all of our 3D models ready for our Maven Pro software, because it's all 3D. Not with 3D glasses or anything, but there's you can manipulate the upper and lower. We can change the bone cuts if they're needed. You can see where the sinuses are. You can see where the nasal dips down. You see how the bridge, the new prosthesis, is going to occlude with the opposing, how much bone we're removing, where the implants are, what type of abutments are needed. Are they angled? Where they're coming out of the prosthesis. So you can see okay, I kind of like number 10 to be out of the cingulum a little bit, so can we tilt it and we can see cross sections of the implants. We're making sure we're not coming out of the buccal plate, or we're not, not needing a heavy amount of grafting. We can see where the extraction sites are going to be. So there's a lot of things that we're looking at, before you guys even touch the patient. Once we have all of the records in here and we do our go-to meeting, that's when, you say, okay, let's do this. We get it. We start, milling everything, 3D printing all of our guides, putting it all together. We assemble the case before it even hits quality control, because that's how there's things that we have to do by hand, the artisan work of the prosthesis. We have to make our gaskets, our bites, everything that you're going to need. So we assemble the case, and we actually send you models of the upper and lower that are articulated without stone, 3D printed, so that you can actually perform the surgery of the all-on-X before you even touch your patient. You can put all the parts and pieces together. You can see how the bone foundation guide fits over the bone, how it's going to sit on the ridge and everything else like that. So we give you a lot of tools, that we feel are necessary to, complete the surgery as we all want it to go.
Okay, so when you guys send it all back, you're going to send a 3D model of the mouth, so I can kind of prepare it once and do it beforehand and say, okay, I feel confident that I can transfer this to the mouth now.
Correct.
Excellent. Now, do you encourage people to do that most times?
Oh, yes, very much so. We have doctors that have been with us for many years who don't need that anymore. But we offer something called a dry model surgery for our doctors doing this for the first time, where you sit down with one of our technicians on a webcam with your case in front of you, and we walk through it step by step with you. We show you how the parts come together, what is called what. Even though everything is labeled, it's still kind of in our vernacular. So, you may need to learn some of our language that we've developed here. So we do that. And that's in about an hour an appointment where, it's like, okay, what kind of materials do I need to pick up the bridge? How does this fit with here? And we walk through it with you, because again, it's just another tool in your toolbox that'll, help you achieve this case the way we planned it.
Yeah, that's excellent. I mean, I don't know anybody else who's doing anything like that. I mean, I think that's where you're kind of virtually doing the procedure, and then you're literally doing it on models, and then by the time you're doing it on the patient's mouth, you've actually kind of done it once in your head, done it once physically, and that's kind of almost like your third time through. So, you're already adapt to, using those parts, putting that puzzle together, and visually in your mind's eye, you know where that's going ahead of time. So I get this thing back. It's got all these parts. I walk through it maybe with one of your implant planners. I feel good about it. I've got the patient coming in. So we got the surgery day. So kind of walk somebody through what we've got. I've got all the teeth. Let's just say I've got the teeth, and are you maybe going to do a bone reduction guide? With that, is it so? We're going to be extracting the teeth, placing the bone reduction guide, leveling off the tops of that, and then placing our implants through the guide. Is that kind of the process with that?
Exactly. So, in a lot of these cases, we're looking for at least 16 millimeters of restorative space on the anterior and 13 in the posterior. So a lot of times we're going to have to level some bone. So, you get your teeth out of there, you lay your flap, you put your bone foundation guide onto the ridge, make sure it sits all the way down. There's no gaps in between the ridge and the bone foundation guide. You have the patient bite into it, anchor it into place. Once it's anchored, you remove what we call the monostrut, which is basically a clear version of the patient's prosthesis, and get them, kind of check the occlusion too, get it into place, anchor it, remove that portion of the bone foundation guide because it's two pieces, level your bone to the level of the bone foundation guide, which is what we planned at our virtual consultation. Then the surgical guide, because the bone foundation guide is going to stay in for the entirety of treatment. It's a stackable system. That's why it's in the name foundation. So the surgical guide is then going to basically fit onto the bone foundation guide like a puzzle piece. And depending on your implant companies, your major three like BioHorizons, Straumann, Nobel, they have mounts and everything that guide the implant as well. So our surgical guides are set up to work with those systems so that not only is your implant is not controlled trajectory, but also depth and timing as well. So we know that if those angled implants are in there, they're in there in the right position. So when we go to put our angled abutments on, they're going to be parallel.
Perfect. So you send the guide, and it comes with the clear version of the prosthesis. It comes on a bite registration. So the patient bites into that. I place my pin guides, fix that in there, remove the prosthesis, level the bone, snap on my surgical delivery portion for the implants, place the implants, and now I can set those with timings to time up correctly based on indicators that are on the guide, and then we're ready to move on to the next phase, which is the pre-made temporary prosthesis. Is that right?
Correct. So from there, once we get our implants in there, we're going to take our surgical guide off. Okay, it's going to lift off of our bone foundation guide. All right. We're going to place our abutments, our multi-unit abutments, and we also have a guide that helps you place those as well if you have all angled. Of course, if they're straight, they just screw down. They're not engaging.
Sure. But there is a guide to help with angled, correct?
Correct, yes.
Okay, yeah, because those can be kind of tricky, I've found it at times.
Yeah, and also, too, we provide you with 8 by 12 photos of certain steps in the surgery, so you can have them up in your operatory and see what we're looking for. And it's not any generic case. It's the quality control photos from your case. Once we have those abutments on there, we put our temp cylinders on, okay, which are cut to follow the lingual side of the bridge for you. Once those are on, you also put in your little block-out straws that go into your cylinders. You take your gasket, put it, it's basically a custom rubber dam that we make here. Goes over your implant assemblies onto your bone foundation guide. Your bridge then goes over that onto your gasket. Put a bite in place. Have the patient bite into it. You inject your material through the facial side of the bridge. The bite and the gasket, make sure that nothing gets on the bone and nothing, comes out of the lingual. There is more in depth. I don't want to give you all of our tips and, tricks, but there is more in depth that the doctors will hear, at their, dry model surgery. But then you pick up your bridge. Once your material's all set up, take out your bite, take out your straws. You've got a clear shot to your screw access holes. Unscrew your bridge, do a little bit of cleanup, get rid of the excess, backfill any voids that may have happened. While that's happening, and this is something that we have that's really trick, is our clear duplicate protocol. So at the time of surgery, you are going to pick up 2 bridges. The patient's long-term provisional, which is a monolithic PMMA milled bridge with a titanium reinforced bar. You're also going to pick up the clear bridge with an identical copy of the patient's prosthesis. Same exact thing. You're just going to do it twice. Okay, now the reason we're doing this is that this is getting all the records we need to go to final. Our abutment level impression, our VJIC, our bite block, sometimes our tooth selection. So while the patient's healing for however long you decide, 3 to 6, 7 months, however, you send that clear bridge back to us while they're healing, we can already fabricate the wax try-in. So by the time they come in for their healing appointment, you already have the wax try-in. All you got to do, unscrew the provisional, screw in the wax try-in, check the bite. Do they like the aesthetics? If that all checks out, get us a new Blue Moose bite because we always like new stuff. Do a light body VPS in between the tissue and the wax try-in. Send all that stuff back to us. Next time the patient comes in is to pick up their final prosthesis. I'm not saying this happens every time because people change their minds, and as you know, patients can be finicky, but we do have the potential from the initial records that you send us before surgery to the delivery of the final prosthesis. There is the potential to do it in only 4 appointments.
Yeah, I think I've got a case going right now. I think I've spent 4 appointments in the try-in stage.
And
Unfortunately,
like I said, doctor, sometimes that's still going to happen.
Oh,
but at
sure.
least we're already at the wax, try-in.
So even when you're converting the long-term provisional, you've still got the bone reduction guide snapped in.
Correct. Yeah, it's still in there.
It's still in there. So after that
sets, against it.
After that sets, we're taking off the provisional. Then we're taking off the gasket. Then we're taking off the bone reduction guide, and then we suture everything closed, and then we clean up underside of the temporary, and then we just screw it down.
Exactly. So yeah, once you have those both bridges picked up, you do just those steps that you just listed there, and then a lot of times you're going to want to check the bite at time of surgery once.
Absolutely, yeah.
But the bite's going to be off.
Yeah,
okay?
No, it always is.
Exactly. So give them a couple days, let the jaw reset. Sometimes blood can pool in that, right between the, I believe it's in between the condyle and the glenoid fossa, and, just from them laying back and, the jaw being sore. So give them a few days to reset, then go ahead and do any adjustments, because we do design these bridges to have beautiful occlusion. Okay. If you put it on that articulator before you put it in the mouth, you're going to see, oh, wow, look at that. Look at how it's dialed in. So don't do anything until that jaw resets, because you may adjust too much, or you may adjust in the wrong place. So, but yeah, once that bridge is in there, you can send them home.
When I deliver any sort of immediate type of thing like this, whether immediate denture or immediate provisional or immediate whatever, I don't even touch the bite, because they've been upside down in the middle of surgery. They're numb everywhere. Everything's swollen, so nothing's going to be accurate. I send them up and say, look, the bite's going to be off, but I don't even want you chewing for 3 days anyway, so it doesn't matter. You're going home, right. You're drinking a bunch of milkshakes. You're going to come back and see me. You're going to have post-op checks anyway, so do the bite adjustments after everything goes down, because it's surprising how it looks way off the day of surgery. They come back 2 days later and it's perfect.
Yep,
so
you got it.
So that's definitely something to remember, because if you start whacking on that occlusion, they come back in, it's going to be different a couple days later.
Exactly.
What kind of final restorations can you do? So I know they're in a PMMA with the metal bar in there for strength, and I think that's fantastic. But what kind of final restorations are we talking at the end? Let's say someone's got 4, 5, 6 implants. They can support any kind of prosthesis we want. We've got nice AP spread. Everything's an option. What are you guys doing for restoring?
Anything that, your local lab can do. Anything from, full zirconia, do, a full zirconia with cutbacks on the anteriors of stacked porcelain, copy mill bars with individual EMAX, crowns. We're kind of going into a realm of some other futuristic style materials that I can't divulge quite yet. But we're always trying to stay ahead of the game. So anything that is traditional for a final prosthesis in the dental world, we can do. I'm
very excited to hear that. And I like anytime you say anything futuristic. I don't even know, maybe it's floating on jets or something. But no, it's good to know that, you've got options. It's not, hey, you have to do, okay, some labs, they only do this, or they don't have the ability to burr out, that zirconia, because that's a big deal. Or I know the cost of some things might be prohibitive, but you could at least do it.
Exactly. And also too, the doctors can also take solace in knowing that not only are, it's just NSequence, but we're part of the NDX family. Okay. So we have 33 other labs, sister labs, that can help us out. Okay, so if you already work with one of our sister labs, heck, that's even better. You already have your reps, everyone's already dialed in, everyone knows what they're looking for. And so, we have so many tools at our disposal to make sure that, the patient is happy, that the doctor is happy, things are done efficiently and correctly. So there's a lot of benefits just by going with us. And of course, I know that sounds like a sales pitch, but it's true. We have a lot more tools than most labs do.
And that's good to know. I mean, it's you need to know the company you're dealing with and the things they support and other things they're doing. And if you've got other labs that you work with, it's, like I said, if I've already got a relationship, why start over? If I've got a lab tech that I'm comfortable with and it's like, oh, okay, well, you guys are supportive with this lab too, then that's definitely a good option.
Sure. And we're also getting ready to unveil our package deals where, say you're gonna send us that final restoration. That's what's gonna happen. We do knock off some of the cost if you're doing the full NSequence guided prosthetic as well as the final. You're going to see a reduction in cost of that final because we want to earn not just your surgical business, but your restorative too. So there is that option as well.
And half of the work is in the setup. So we've already go through that song and dance together. We've already got that end in mind. We've already done all that. It's basically just copying the provisional with the changes to the final. So most of the work's already done. It's like, why at that point, why bail ship and go somewhere else?
And but we understand if you have that lab that you've been working with for however many years, it doesn't completely hurt our feelings, but we'd still like that business.
Yeah, that's great. Now, we can do it all. We can do some of it with you. We can do the surgical and temporization with you, or we can take it all the way to finish. Now, let's say someone's placing a lot of implants. They've got some full arch they want to look at, but maybe they've never done one of these. I mean, who do you guys partner with for training? Do you guys have some doctor training available? Do you guys have places for docs to go with CE? I mean, kind of talk to me about that, because I know it's good to do the walkthrough. I mean, I think it's good to do the dry run, but getting some guidance in this stuff. I mean, this is pretty big stuff. So what do you guys have worked out for that?
So as of right now, we have, of course, Dr. Picos, who does both courses in Florida and Southern California. And we also have Dr. Berger, who does classes with Permadontics down in San Diego. So we have both of them teaching, classes on our process. They can look up on our website. We have both of them listed with information. So you can go to NSequence.com, which is just the letter N, SEQUENCE.com, and you can look up all that information on those classes.
Okay, so we've got the Picos class. He's got a guided full arch immediate implant reconstruction comparable to the same day teeth and all on 4. And so he basically is kind of working through this process and using your guys' sequence for that. And then you've also got Dr. Berger and Dr. Aries?
Yes.
Okay.
Correct.
And they're down in Permadontics, and you said that's in San Diego. So that's a 2-day, fully guided seminar, basically kind of the same thing, working through all of these all-arch combinations. Is that correct?
Yes, that's correct.
Okay. So do we schedule through those institutes? Obviously, we're not scheduling with you guys, but we basically give those institutes either Picos or Permadontics a call and say, hey, I want to take this seminar, and we do it through them.
Correct. That is correct.
Yeah.
Yes.
Is there any discount you guys give for being referred to there, or any kind of whatever?
If they have something, they haven't told me yet, so I'm not too sure.
Why don't you work on that and let me know?
Okay. Yeah. And of course, if they go onto our website and they ask any questions, we have a team of people that are ready to answer their questions. It's not something where, we get back to you in 24 hours. We're usually hearing from us within, an hour of you sending that email.
Sure. Now, I know Dr. Picos has a lot of courses that he offers. Is the
he does.
Let's see, is the Permadontics, do they offer a lot of courses as well, or is this kind of the only thing that they're doing right now?
I believe they offer other courses. Don't quote me on that, but the only ones I've ever dealt with are, with us.
Well, and that makes sense, because that's kind of what you guys are doing. If a doctor's interested in saying, hey, I want to give you a try, or I'm ready to jump all in with both my feet, what's the way to do it? I know I just kind of signed up, registered online, and I got the information packet, and I feel like I'm ready to go. Is there anything else dentists need to know, or is that the best way?
That's the best way to do it. And we're always, once we know, we find out, new doctor, you get your new doctor packet. We also set up a new doctor call. Okay. So you sit down with sometimes me and sometimes some of our admins, and we talk. We just say, hey guys, this is what we need. Not only are you getting in the information on your podcast here, but we'll sit down one-on-one and, talk to the doctor and their team if they want and be like, hey, this is what we need to get started. Let us know when you send it in so we can, quality control your first couple cases, those sort of things. So we set up new doctor calls as well. Then once that gets started, you send us a case, we start working together.
So it sounds pretty seamless. I think you guys have a lot of things figured out, and really have the headaches taken out for people. And anything else that we didn't cover that maybe someone would want to know, or maybe frequent questions you get asked, or frequent concepts or issues that you have come up that you want to share with me?
No, because we've done it so many times that we've just sort of put the answers that a lot of people ask into our spiels, as it were, as we're talking. We're reaching, I think, the 10,000 mark on all-on-X cases for doing this procedure. So, it's, you have a team on this side, that's done a lot of these, found like, hey, guess what? On this one here, this is going to be a little sketchy. So we might want to try this, or this. And we're never going to tell the doctors, hey, this is how you have to do it, because that's not what teams do. We bounce ideas off of each other. We figure out a course of action, and we use teamwork and compromise to get it taken care of.
But it is reassuring to work with someone who's done it a lot and can help guide you, because, and that's the thing with any good lab. Good labs can make a dentist better because, I only know the cases that I do, but a good lab sees the cases that hundreds or thousands of dentists does and say, hey, maybe we should steer in this direction, or maybe have you thought about that? And I think that's just going to make you a better clinician if you partner with a good lab and allow them to help coach you a little bit too. So I encourage everyone to do that a little bit.
Agreed.
Well, perfect. I'm excited to get this. Let's say someone kind of actually knows what they're doing a little bit and does the dry run and does all that. What kind of chair time are you seeing for someone? Let's say I just want to do an upper arch, and I'm slicking teeth and screwing in some implants and putting in a temporary and all that. And maybe this is my first time working with you and all that, but I've got a lot of experience. What's your average chair time? Possibly
for the initial one, anywhere between 2.5 and 4 hours. For the first one.
That's not bad in a half day's work, though.
Sure, and in our world record for someone who's been doing with us for a long time, 1.5 hours.
So maybe I've got that patient booked next week for 60 minutes. Do you think I should drag that out a little? I'm just kidding. Yeah. I'm just kidding. So maybe an hour isn't quite realistic, but
I like the verve and candor you have there, doctor. But let's pull back on the reins a little bit for the first one.
No, but it's good to know kind of what you're dealing with. I think if anybody who's done some of these the traditional way, let's just call it, I know there's a lot of headache that you guys have cut through for people. There's a lot of you're just taking the guesswork out, and I think that's what anybody wants here is how can we be predictable? How can we cut down surgical times? How can we be efficient and increase predictability? And I think you guys have definitely figured out a great system for that.
Yeah, it's been said through the lab for many years. For what we do is we would rather be proactive than reactive.
Absolutely. Well, Charles, I won't take any more of your time. I'm really excited about your product. I think you really know what you're doing, and your company's got a great handle on things. So I'm excited to get some cases out with you and get going with that. And maybe after I do that, we'll get a follow-up call and kind of circle back and kind of dive in deeper.
I'd love to do it. We always welcome any kind of feedback you can send us. We don't get the opportunity to be in the operatories and be out there and, see how things are going. So any feedback any doctor can give us on what we're doing is always welcome. Positive or negative, we'll take it.
Excellent. Well, I appreciate it. Thank you for your time today, and we'll speak with you later.
Awesome. Thank you so much, doctor.